I'd like to introduce to all of us our virtual pre-recorded speaker who is going to join us then for a brief discussion we're going to have after that. So our pre-recorded video is going to be by Michelle Williams, who's the Dean of the THN School of Public Health at Harvard University. And just a word about Michelle. Michelle is an internationally renowned epidemiologist. She's the Dean of the Faculty, as I said, and the Angelopoulos Professor of Public Health and International Development at the Chen School of Public Health at Harvard University. She's an award-winning educator, a public health scientist, and a widely recognized academic leader. Her scientific work emphasizes reproduction, perinatal, pediatric, and molecular epidemiology. So Michelle will join us here in person, but first I think we'll show the video that was pre-recorded by Dr. Williams.
Hello everyone, and thank you, Yoel, for inviting me to be a part of this year's summit. It's a pleasure to be here with so many clinical scholars and practitioners who are improving women's health and thus human health around the globe. In many ways, this meeting feels like a homecoming for me. Long before I became dean at the Harvard Chan School of Public Health, I directed a perinatal and reproductive epidemiology program embedded in a large maternal and fetal medicine research unit in Seattle. It was a special time in my career, and the work I still find humbling to have been a part of it. I could be 100 years old and I'd still feel the very same way. I'm astonished when I think about how much has changed since the late 1980s, when I first started working on the causes and the consequences of adverse pregnancy outcomes. It was before the NIH Revitalization Act of 1993, which opened the doors of inclusion for women and minorities in government-funded research. It was also before the Beijing Declaration and the Platform for Action, which gave us a global framework for gender mainstreaming to advance the rights of women and girls around the world, including the rights to health. We have made some incredible strides these past few decades, thanks in no small part to many of the people convened today. Globally, maternal mortality has dropped sharply, 44% between 1990 and 2015. Infant deaths have declined even further to the lowest levels in history. While political and cultural barriers are still pervasive, the Texas SB law as just one example. Today, more women around the world have access to safe and effective forms of contraception and family planning resources, which have given them more autonomy over their bodies and their lives. At the same time, once taboo concepts like period poverty and gender-based violence are now part of public health dialogue. All of this has put today's women and girls on a path towards greater health and equality than their mothers and their grandmothers. And that will have a ripple effect on the well-being of their families and their communities. The progress we've made should remind us of what's possible, and that progress should inspire us all through the work that we still have to do. That's why gatherings like this one are so critical. This is the chance to pool our collective expertise, to examine the opportunities and the roadblocks that will shape women's health in the next century. It is also an opportunity for us to find innovative ways to address these roadblocks together, because the challenges are real. Today, women and those assigned female at birth are still suffering from a historic lack of investment, understanding, and regard for their health needs. Even the term women's health has been alarmingly narrow. Historically, to the extent there was interest in the field, It's been in the issues that only affect women, like sexual and reproductive health, maternal and infant health. These are critical, of course, but at the end of the day, placental abruptions, premature labor, or preeclampsia, the topics I devoted so much of my time and energy to in my career, are only pieces of the puzzle when it comes to women's health. Today, the leading causes of death and disability for women are non-communicable diseases. NCDs, for example, make up 7 of 10 leading causes of women death worldwide, and that's up from 5 out of 10 in 1990. In the United States and across all ages, heart disease is the #1 killer of women, accounting for nearly 1 in 4 deaths a year. The next leading cause of death is cancer, followed by chronic lower respiratory diseases, stroke, and Alzheimer's. And when it comes to women, our knowledge of NCDs is dangerously limited. For example, women are more likely than men to be misdiagnosed after a heart attack, and they are more likely to die from one. That's in part because women don't always experience classic symptoms, like kneeling over in distress, as we've seen in the movies. And by classic, I mean the symptoms that we see in men. Instead, women may experience subtler symptoms, like back pain or even fatigue. Moreover, women patients and their care providers often overlook those symptoms because heart disease is still erroneously seen as a men's health issue. All told, a woman dies from heart disease every minute in the United States. Every minute. So how did men become the poster people for heart disease and the default standard for the diagnosis and treatment? The fact is, health research and innovation has long been for men and by men. And that's true not just in heart disease, but across the board. Let me elaborate on that statement a bit more. In 1977, the FDA recommended women of childbearing age be excluded from clinical studies. This was a recommendation that was designed for protecting the most vulnerable, that is, unborn children. This was particularly in response to the devastating exposure to drugs like DES, diethylstilbestrol, a synthetic form of estrogen that was prescribed to millions of pregnant women until 1971. The drug, DES, was not only ineffective, but also put those women at risk of rare cancers, and it jeopardized the health of their infants as well. To this day, DES daughters are at a higher risk of clear cell adenocarcinoma, premature birth, and miscarriages. Ironically, the very problems that their mothers were prescribed DES to prevent. It's a stark example of the systemic devaluing of women's health and the intergenerational impact of that devaluing. This tragedy endures not just for the women and infant directly exposed to the drug, but in the erasure of women from the healthcare data that followed. The exclusion of women from research has been so pervasive that even laboratory rodents have typically been male. Why is that? Because hormonal variation in female laboratory rats produce more complicated data. That means more test subjects are necessary and more costs for the same research. Instead of solving those variations, women were removed from the equation altogether. And it's been justified by the belief that what worked for men would also work for women. That's why women have long been dosed and treated not as women per se, but as smaller men. Even later, once women were more widely included in clinical trials, that data was not always disaggregated by gender. In fact, a landmark study from 2011 found that most clinical research done on heart disease in the past decade, did not disaggregate the data of men and women. So, experiments performed, medications tested, procedures practiced, all intended to mimic responses that a human would have, did not isolate and therefore discounted the reactions that a human woman would have. Essentially, like so many facets of society, we've designed medicine and health systems for men. And that has been catastrophic for diagnosis, prevention, and treatment. We saw this quite clearly during the COVID-19 vaccine trials. Aside from children, pregnant women were the last in line for inclusion in empirical data. This was despite their elevated risk of severe illness from the disease. And because of this, the data were not there to make definitive, timely recommendations when vaccines were initially released. That led to unnecessary but understandable fear, concern, and hesitation among pregnant women about whether or not they should get the shot. And here's another example. Women are more likely to experience side effects when using prescription or over-the-counter drugs because their doses have historically been formulated for men. Researchers recently analyzed data from thousands of medical journal articles and found a clear gender gap in dosing for 86 medications approved by the FDA. They included everything from antidepressants to cardiovascular and anti-seizure drugs. Women took the same doses as men, but they had higher doses of the drugs in their systems for longer periods of time. And they had adverse reactions twice as often as their male counterparts. Between 1997 and 2000 alone, 10 drugs were taken off the US market because of life-threatening health effects. 8 of those 10 drugs posed greater health risks for women than for men. And that's just the drugs that were pulled from the shelves. All of this is to say that a one-size-fits-all approach is devastating for women's health. And it's high time for a new gendered paradigm. All of us, researchers, clinicians, and policy makers alike, have to start asking ourselves, historically, who has been missing from our research, and how can we correct that? We have to analyze the data we collect, both routine health data and clinical research data, for sex and gender differences. We have to identify the root causes of the disparities that we find. And we have to ensure those findings are applied at both the clinical and population level. Moreover, we need a global agenda that takes a broad, life course, transdisciplinary view of women's health, one that accounts for her whole body and mind. We need to take an holistic approach. That means focusing on how women, and particularly women of color, are uniquely impacted by the social determinants of health. We know that the conditions in which we live, work, and age account for 80 to 90% of our overall mental and physical well-being, far more than our access to medical care or our genetic makeup. And these issues are intertwined with racism, sexism, and structural bias. Look no further than maternal mortality here in the United States. As so many here are well aware, while we've made progress globally in the US, Black women still die at a rate that ranges from 3 to 4 times that of their white counterparts. Racial discrimination in maternal health care is a significant factor. also is unequal access to prenatal care. But injustices begin long before a woman becomes pregnant. In 2018, the CDC determined that many of these maternal deaths occurred because of broader failures of social support, or rather, upstream causes. One way is through chronic, unrelenting stress, like living paycheck to paycheck or dealing with relentless racism, which can lead to wear and tear on our minds and on our bodies. Such stressors contribute to a cascade of adverse health outcomes, among them heart disease, obesity, and stroke. The work of Harvard Chan School alumna Arlene Geronimus hones in on the negative impacts of chronic psychosocial stress on maternal health. Her research has shown that stress hormones triggered in fight or flight scenarios siphon energy from other physical functions, including those that support a healthy pregnancy. To quote Arlene Geronimus, living under chronic stress is like facing tigers coming from several directions every day. She has coined a term for this corrosive damage, weathering. And what she's finding is that the damage only compounds as time goes on. It's not just mothers who are affected, their babies are as well. A study by the American College of Obstetrics and Gynecology also found that the stress associated with the daily experiences of racial discrimination can increase the risk of problems like preterm birth and low infant birth weights. This is just one example of chronic stress and the social determinants of health in action. Women, and particularly women of color, are overrepresented in low-wage jobs, which hurt their economic security and their access to health care and their mental health well-being. Women-led families are among the fastest growing segment of the homeless population, thus putting them at high risk for injury and illness. And women are far more likely to be the victims of intimate partner violence, which impacts not just physical, but mental, sexual, and reproductive health. Everything we are learning about the connection between racial disparities, gender bias, socioeconomic realities, and our biology reinforces a central fact. Improving women's health necessitates addressing the social determinants of health. In fact, I'd argue that being a woman is a social determinant of health. And because being a woman is a social determinant of health, we need to be willing to look at the unique ways women of different backgrounds experience the world alongside medical and biological factors. Of course, collecting data of the necessary breadth and depth is a formidable challenge. To date, some of the most comprehensive data we have on women's health is from the groundbreaking Nurses' Health Study, which was launched in 1976 to examine risk factors for major chronic diseases in women. The original cohort has since expanded to include multiple offshoots with more than 280,000 nurse participants. All told, this research has supported hundreds of scientific papers and countless new findings on a range of diseases and health outcomes. It's an example of what's possible when we're able to collect rich, long-term health and lifestyle data across a vast cohort of women. But there's a reason nurses are such a successful study population. They have exceptional knowledge of health and the ability to provide researchers with accurate, detailed information about their daily lives. That isn't so for most people, particularly vulnerable populations. Fortunately, more than 80% of Americans now have smartphones, which offer all kinds of real-time, granular data about their lived experiences. Our mobility, our sleep patterns, our diet, our social interactions, even access to green space, and so much more. And advanced analytic tools, advanced computational tools, now allow us to collect and interpret that data on a scale previously unimaginable. In light of this, the Harvard Chan School has partnered with Apple and with NIH to launch a first of its kind longitudinal research study on menstrual and gynecologic health. We are collecting iPhone and Apple Watch data from volunteers over a period of decades. That anonymized data, unprecedented in size and scope, will allow us to explore the relationship between demographics and lifestyle factors as well as menstrual cycles. And that is critical because menstruation is more than just a reproductive function. It's a window into a woman's overall well-being. And treating it as a vital sign could lead to a greater understanding of women's health across the life course. And our hope is that this study will give us new insights into a range of disorders, including polycystic ovarian syndrome and endometriosis, which are very common and yet frequently go undetected or misdiagnosed. We also hope it will help demystify menopause, which continues to be drastically understudied by the medical community. This study is just one example of the kinds of investment that is long overdue, and it's a recognition that our work requires a readjustment in perspective and partnerships, because the enterprise of women's health is so much bigger than the part of it each of us works on. The reality is the interventions must be as intersectional as the issues are themselves. That's why it is so critical to have a spaciousness of thinking, to look around at the upstream factors that influence the issues we see in our clinics and in our laboratories, and why it's important for us to build coalitions across other fields and specialties that allow us to treat these issues holistically. That is what this summit is all about. And I am excited to continue this conversation, to move that work forward with all of you. I thank you for your time and for the honor of your attention.
So thank you very much for joining us. And I'd like to introduce our panel. Three of us are virtual, and Dr. Miller and myself are here in person. So maybe I'll first introduce Dr. Miller, who is here with me in person. Elizabeth Miller is a professor of pediatrics, public health, and clinical and translational sciences, and the Edmund McCluskey Chair of Pediatric Medical Education. And she's also the University of Pittsburgh Director of Division of Adolescents and Young Adult Medicine, and the Medical Director of Community and Population Health at UPMC Children's Hospital here in Pittsburgh. It's a great honor to have you here, Liz, and also it's a great honor to have Dr. Al Reese. Thank you very much joining us from Maryland. Dr. Reese, if you don't know, is the Executive Vice President for Medical Affairs at the University of Maryland in Baltimore. He's also the John and Akiko Bowers Distinguished Professor and Dean of the School of Medicine and Professor of OBGYN Medicine and Biochemistry and Molecular Biology. Dr. Reese is also the former Vice Chancellor for Medical Sciences and Dean of the College of Medicine at the University of Arkansas. Also, we have with us our participant from yesterday, Dr. Maureen Litchfield. She's our recently appointed Dean at the Graduate School of Public Health here at the University of Pittsburgh, and a Professor of Environmental and Occupational Health, the Jonas Salk Chair in Population Health, and prior appointment at Tulane University, as well as the CDC and the U.S. Department of Health and Human Services, the Agency for Toxic Substances and Disease Registry. Thank you very much, Maureen, for joining us again. And Dr. Williams, Michelle, I just introduced you before we watched your video, so thank you very much. But I think Dr. Rees and Dr. Litchfield probably know you. I know Dr. Miller knows you very well, but just to remind all of us, Dr. Williams is the Dean of Faculty and Angelopoulos Professor of Public Health and International Development at the Harvard Chan School of Public Health at Harvard University. So terrific to have all of us here, and I'm gonna join sitting down here next to Dr. Miller. Your words were so impactful and meaningful at your presentation today that I really think it would inspire our discussion we're going to have now on stage with the three of you and with Dr. Miller and myself. Throughout our summit, which I hope all of you have been able to see at least parts of it, I know Maureen was here for part of it. Throughout our summit, we had discussions of numerous topics of development and shaping health, mental health and metabolism. And everything we talked about was through the lens of diversity, inclusion, and of course, access to care and to very diverse populations. And I want to maybe start by taking a deeper dive into issues related to diversity, equity, and inclusion in our research and healthcare provision. And of course, we do everything from the point of view of women's health, but that really has direct application to public health and of course to human health overall. So my first question, maybe I'll start with you, Liz, is trying to go a bit beyond the number of people of color we see in our faculty and our staff and our healthcare force. What I mean by that is, of course, it is very important for us to have more and more people representing minorities, more faculty and more people in our research and healthcare force representing different minorities. But I want to go beyond it a little bit because I think our numbers need to increase, but I'm not sure it quite satisfies our need as a society and as a community to place more emphasis on greater access to minorities, better way to address diversity and access, and of course, equitable care and research. Would you like to comment on that,
Absolutely.
please?
Thank you so much. And it is deeply humbling for me to be on this panel and Dr. Williams to hear your lecture. It's a tremendous fangirl experience for me. So thank you for your incredible leadership. And to your question, right? And I think that you had asked us, Yoel, to be a little bit disruptive in our responses. So, as we think about diversity, equity, and inclusion, and certainly in terms of workforce development and building our research teams, I'm going to start by answering that when we center the voices of community members, and in particular, centering those who've experienced profound marginalization and minoritization, as Dr. Williams was referring to, that we really start to see a different way, a different pathway forward towards systems level transformation. And as I was driving here today to participate in the summit, I was also deeply troubled by an event that happened here in Pittsburgh last evening, where one of the leaders in education, Mr. James Harris, who is one of the local school superintendents and has been the first superintendent to be daring enough to get police out of the Woodland Hills School District. And he was terminated last evening by the board for his failure to address violence in the school. And it is so sad for me because as we think about workforce development, as we think about diversity, if we don't address things in school age and in adolescence and do something to stop the school to prison pipeline, here we are in the city of Pittsburgh where we have some of the highest rates of school suspension and police referral. And you say, well, Liz Miller, what does that have to do with women's health? And it is everything to do with women's health in that Dr. Williams was posing and pushing us to think holistically. And it is not enough for us to say, well, we're happy doing STEM programs in our schools. We actually need to lean in and think even more deeply about partnering with our schools to support them on their health and wellness initiatives if we're actually going to start moving the needle towards what we really aspire to.
I appreciate those comments very, very much. And maybe I'll shift to Dr. Reese. Al, it's so great that you can join us from Baltimore. Thank you very much. Al, at the University of Maryland, of course, I know you've been paying very close attention for multiple reasons, very close attention to increasing diversity among the faculty, staff, and many other people in research, education, and healthcare. What are the things we're doing beyond just the numbers? What are the things we're doing really to educate people about the true value, how diversity improves our science, how does the content of better addressing deeply diverse issues really improves what we do in the academic setting?
Thank you, Yoel. It's a pleasure for me to be here. I'm sorry that I can't be physically there today, but the technology that we have between us allow me to feel relatively close to Pittsburgh. So once again, thanks for inviting me. Very good question. One has to be purposeful. And so we don't want to begin by claiming that we have solved anything or solved everything, but we believe that we have made an impact by purposeful actions. And you mentioned the workforce. I'd like to address that. When we look at the workforce, the research workforce or the educational workforce, I saw that there clearly was an opportunity for the University School of Medicine in particular to make a difference at the time. And so a number of things that we purposely did. 15 years ago, when I became dean, I started a thing called a research career development with an emphasis on women and minorities. So we want to basically provide education, training. 14 years later, we really have seen the impact, the benefit of that. Increased numbers of successful independent researchers and folks who have access now to intensive writing or experiential learning. So we can really diversify the workforce in that way. And we're actually moving to a much more comprehensive program at the present time to really involve training. So my point is that it's not going to happen simply by wishing it to happen. I believe that one has to invest resources in creating the type of initiatives, whether it happens to be programs to help everyone, but with an emphasis on women and minorities. In doing that, one is able to purposefully increase the workforce. That's my first point. The second point is that one has to change the culture. I remember making an analogy once when I spoke to the department chairs. I said, diversity is fundamental. Diversity is science. As I take, for instance, a rose, a red rose. It's beautiful. Everybody agrees. But put a white one beside it. It's even more beautiful. In fact, put a whole bunch together, a bouquet. And I gave an example of a symphony. And I had the string played by itself. Very nice, real symphony. Then I had the horns played by itself. And then I had the whole symphony play. And my last example was a DNA molecule. You know very well that the nucleotides ATGC are really fundamental to the DNA molecule. But if you have multiple repeats, A, T, it's a disease. Fragile X, as a result, is multiple repeats. So homogeneity in biology is disease forming. Heterogeneity is actually health. So in using those types of, a little humorous, but at the same time with a scientific basis, you're able to get people to appreciate the fact that the diversity that one seeks should not be, beaten over the head, but it should be done in a way that it is enjoyable, like making sure you have more colleagues who will be submitting grants and securing grants and being promoted and we can celebrate everyone. So that's the approach that I've taken, you all. And again, it's not solved, but I think that we've made significant progress that would love to see continue.
I think you have, and I think the musical metaphor you use is very telling and very helpful to conceptualize it. And maybe I want to ask your two other colleagues, maybe Maureen, you have recently, took on the position of the Dean of the School of Public Health here. And I think that our School of Public Health here at the University of Pittsburgh has done very good things for the academic community, the community at large in Pittsburgh. But I'm sure you saw some new challenges and opportunities that you can really advance the cause of enhancing diversity in a more meaningful way than just the things you've seen done so far. And I wonder, what are some of the opportunities you have identified and you plan to do in the next few years?
Yeah, again, just like others said, it's great to see colleagues on the phone. When I came here, one of the things I missed greatly was being in the communities because of COVID. I feel enclosed in this office, and I want to be out there so much. Diversity, equity, and inclusion was one of the 4 priorities that I came in with. And I was recently asked, I'm going to chair another search for another dean in the university, and I was asked, well, why did you come as a new dean? I said I came for 2 reasons. 1, there are a tremendous amount of assets here of the things I'd like to do, and 2, the significant investment that the university is making. But it is much beyond, as both Michelle and Al has said, it's much beyond the numbers. It's about the mentorship, and it starts. And so I am putting in funds, my personal package funds, into a public health science academy that starts in juniors and seniors in high school. And they will graduate not with a piece of paper. They will graduate with a 3-credit course that puts them into the Bachelor's of Science in Public Health that we just established. So it's embedding it. The other thing that I would say just broadly, and perhaps that's another question that you will go into, Michelle really sets the stage for us to think different. And so I am always worried, since my time at CDC, why we make something special. Women's health is not special. Women's health is what we do every day. And so when we embed it, then it becomes like brushing your teeth. You don't think about brushing your teeth several times a day. And so it must be transgenerational. It must cut across the research continuum. It must involve the whole woman and the whole environment around the woman. That includes the cultural environment, the socioeconomic environment, the housing environment, the transportation environment, all of that. So until we do that, we keep on making women's health separate, different, and special. And younger people have a connotation about what special is. We don't want that. We want women's health to be everyday's health and women's health to equal public health.
Yeah, I agree with you completely, and I think your words are very impactful. I have to admit that when I think about these things, and including from the point of view of women's health, but from the point of view of health disparities and how research can impact health disparities, I sought some additional resources for myself, being a white male, to truly understand more deeply the meaning of diversity and how it potentially impact our academic environment and academic work. Michelle, I happened to read a book just recently from one of your colleagues at Harvard, Tommy Shelby, who is an African-American philosopher. And he talked about his different approaches to how people of color can really unite in a very positive way to make a difference, including in professional spheres, professional dimension, I would say, including, he did not speak specifically about women's health, but he did refer to ways to organize to make a difference, from street demonstrations to ground-up academic activities. And I wonder, at the Harvard environment, what are things that you have done in your school and also you can see done in the overall Boston environment that really just exceed seeing just more numbers of colored people?
Yeah. Thank you, Yoel, for that question. And I just want to say, what a privilege to be on a panel with these esteemed colleagues. You know, I think what we are seeing in the Boston community, and I know this is true also in your community in Pittsburgh, is we are recognizing even more potently and embracing even more intentionally and purposefully partnership. The problems that we are all, grappling with are not going to be addressed with the old single disciplinary siloed approach to problem solving. And so what I'm seeing, and I think this pandemic has accelerated this embracing and operationalization of real team science, real transdisciplinary work that embraces adding diverse voices in every way, diversity in every way, to bringing about a team that addresses the problems that are as complex as they are. I loved Dr. Reese's analogy of the symphony. Heterogeneity helps build resilience, and it's what we need. We need to build educational systems, policies, institutions in a more resilient and robust way to face these complex threats. And doing that requires a commitment to team science, an intentionality to having diverse voices, domestically as well as globally. And it requires an engagement and partnership in ways that we've not always had our institutions positioned for. The other thing that I love about Maureen, your vision of bringing public health lessons down to high school students is something that we're all grappling with here in Boston as well, because some of the challenges we're facing is due to a lack of health literacy. And when you have a global health threat that requires individual action as well as government action across ecosystems, you have to have a literate general population and well-trained leaders who understand health is involved and embedded in all policies. So I think what we're seeing, Yoel, is more intentionality in understanding across disciplines and a real engagement and understanding that the problems that are threatening us, climate change, inequality, structural racism, requires a commitment to bringing all disciplines, domain expertise together.
I appreciate very much what you're saying, and I really appreciate your words about commitment. I want to go back for a second to Michelle. One of the things you presented in your pre-recorded video has to do with one of the specific measures of maternal quality health, and that's related to maternal mortality and also infant mortality, which, as we all know, much more greatly affects people of color, especially African Americans in all of our communities across the country here. And as you mentioned, Michelle, the incidence of maternal mortality is 3 to 4 times higher. Infant mortality is also about the same proportion higher. And that ratio between African Americans and whites has not changed in the last several years. Although we've seen some decline, even here in Pittsburgh, we saw a small decline in infant mortality, more in the colored population. Still, this is still a remaining issue, lingers across what we do. So maybe, Al, if I may ask, in Baltimore, which I know this is one of the key issues that you're probably addressing from the diversity point of view, what are some of the things or strategies you've been thinking about to try to have a very tangible effect on reduction of maternal mortality and infant mortality, especially for minority populations?
Thanks, Joel. So we have a number of programs. In fact, we have a large program, it's a grant-funded program called Be More for Healthy Babies. It's, Be More for the Baltimore. And that has been a fairly, it's taken a number of zip codes where we have, led by one of our pediatricians with a public health background. And so there's a large population of folks who go out to educate young women, families, mothers in particular, regarding their prenatal care, the need for prenatal care and continued prenatal care. I hate to say it this way, but it's not rocket science. Infant mortality, the two major causes of infant mortality are prematurity and birth defects. And so if we can reduce those two in particular, there are other causes, but we can have a significant impact. Now, prematurity is multifactorial, as you know. So the folks, my faculty, are actually working on the prematurity end and less so the birth defects. And that is through either prenatal care, active prenatal care, involvement with education. So grandmothers understand that babies should be sleeping on their backs, back to sleep, as opposed to sleeping else on their stomach, and basically ensure that they follow certain basic community health practices. So that has been quite aggressive. The infant mortality rate in Baltimore is actually within that, it's a multiple zip code here, has actually fallen based on a multi-year commitment to community education and community engagement. This has been the School of Social Work has adopted a few zip codes, and they have their students spread out in the area. The whole point I'm trying to make is that education does work. Education does work. Another point I want to make, you all, and I think this is not so obvious, and I've had a lab for all my life, and one of the things that we have been studying is really birth defects, but birth defects in particular that is induced by diabetes. So mothers who have diabetes, type 1 and type 2, have a disproportionately higher rate of birth defects, 5 times more than the background rate. But here's the issue. It really relates to poorly controlled diabetes, because if a mother has very well controlled diabetes, tightly controlled, the rate of birth defects is comparable to the non-diabetic population. So we find even health disparities in birth defects, even though in fact it's a metabolically induced disease. But it has to do with, again, chronic care. If in fact a mother is not very attentive to achieving euglycemia, that is a basis for inducing birth defects. So I've always said sometimes it's a fairly easy concept that the achievement of euglycemia before pregnancy and during pregnancy result in the best outcome. But that's easier said than done, because glycemic control is not always easy to achieve, and it's even harder to maintain. And there's some great studies in Germany, in Israel, in England, that has demonstrated without question that when you randomize patients to tight control before pregnancy, the birth defects rates come all the way down toward the background. And those the control that are in usual care, they have a much higher, multiple times higher than the background rate. My only point is that to the extent that we can provide community education and engagement, in other words, not just kind of for a helicopter, you come in and you give a speech and you leave. You have to stay and have to educate, and sometimes even a multi-generational education, both for prematurity and for chronic diseases, one can make an impact. And we are seeing an improvement. We actually celebrated a reduction in infant mortality in Baltimore, in large measure associated with the long-term Be More for Healthy Babies.
Yoel, if I can,
please.
I just want to say how important it is, in addition to the education, that, what Al is saying is it's so important to think about the upstream preclinical factors that are the social determinants of health. In other words, adequate housing, living with secure foods, an environment where you can control stress. These are all those upstream behavioral determinants, social determinants, that would determine whether or not a woman conceives when she's got, when she's euglycemic. And that's the potent issue here, that those social determinants way upstream before the clinical care factors kick in have to be a part of the solution and the equation when we're thinking about a holistic approach to health and wellness.
I very much appreciate what the two of you just said, and I think it relates to the withering effect that you spoke about, Michelle, in your video, that can lead to cumulative stress that ultimately affect our health, and it can be all preclinical, but then once it hits us, it really hits very badly, this cumulative effect. I have to admit that also yesterday, Maureen spoke about some of the environmental effects that add to this type of stress, and just taking all of this together, it really makes me more appreciative, Al, of what you're saying about the statistics improving in the Baltimore area. I want to ask Liz Miller. Liz, as a pediatrician and one who's very much engaged in community health, and I want to emphasize health outside of the hospitals,
right,
which is something you're so passionate about. After all, people don't want to live in hospitals. They don't live in hospitals. They live in homes, and the best preventive care would be provided before the hospital, of course. So how can we take what we're trying to envision as the proper preventive approach in communities, in non-hospital environments, and preventively intervene in a way that can truly diminish the withering effect, improve health, diminish the need to go to the hospitals, and truly make an impact, especially on minority populations?
Thank you for that question. And I'm going to say that and remind us, right, that as the pediatrician, while children are 20% of our population, they are 100% of our future. So investing in children, young people, their families, and recognizing that our commitment to environmental justice, right, as Maureen has so eloquently underscored for us, is really about making sure that our children are thriving, not just surviving. And as we think about upstream, I started by talking about school suspensions because part of our challenge with doing research in the space of health and wellness is forcing ourselves as scientists to think more broadly and to partner more broadly. And Michelle, you were pointing out team science, and one of the great kind of adventures, experiments that we are embarking on in Pittsburgh is called the Pittsburgh Study. Maureen, Yoel are part of this collective impact work where we have community members deeply embedded in our team science as citizen scientists as we work together to co-create interventions that are relevant to the communities in which we are working. And so really striving to do research with community, as Al was pointing out, right? This can't be an in and out, it needs to be sustained relationships. And I think it's just, for me, the Pittsburgh study brings so much joy because our community members are leaning in to help us design what makes the most sense in terms of transforming the health and wellness of our future.
I have to admit, I feel like the five of us, we're really in a brainstorming session here that outlines so many important principles. I have to also be cognizant of the time. And as the organizer, I have to set example by making sure we end on time. And we really have just 30 seconds. So as we end, I just want to ask each of you, maybe in 1 or 2 words, if you can just educate all of us, what do you think would be the one most important metric we can use for our success in diminishing, I would say, health disparities, especially among minority population, and improving our attention to diversity, equity, and inclusion in our scientific spheres or our biomedical spheres? What would you say would be one most important metric? Maybe I'll start with Maureen. What would you use as the most important metric for success?
Is 100% well-being in women, not only 100% health. So how do we get 100% well-being? And looking at our population, not only where we are, and we have to work where we are, but where most of the problems also are, and that's globally. I want to emphasize Michelle's point of looking globally. For me, the non-chemical stressors are much more impactful in terms of people's health and women's health. And so a holistic approach, 100% assuring women's health and well-being is what I'll be striving for.
Thank you for this. Well-being, prevention, and let's say wellness would be key. Dr. Rees, Al, please.
Since you have restricted me to only one word, it's kind of, but I'm going to try to get a sentence if I may. An extraordinary emphasis on promoting education, because I believe by so doing, one begins to appreciate or aspire to be better every day.
I so much appreciate of what you're saying. I believe in education being a solution to so many of the world's problems myself, so thank you for this. Michelle, please.
I'm going to have to cheat a little bit and say all policy has an impact on health. And so we have to recognize that all policy has an impact of health, and all policy should have threaded throughout it commitment to equity, racial as well as gender equity. And when we think about health policy, it's not just health policy. As Liz has indicated, it's education policy, it's housing policy, environmental. And that's what I mean about all policy relates to health, and equity has to be threaded throughout every policy evaluation we make.
This is terrific, and probably all of them have to be implemented, not just one of them. Mm-hmm. All of them have to be implemented. Thank you for this. And Liz, I'll let you have the final word.
Wow. So I think I would say thriving communities. So that we're thinking about ourselves as connected with each other, that we're, the five of us, as you were saying, brainstorming, right, creating community, but that in that, as we think about community and the many communities that we are part of, that we aspire to thriving, and what that means for us to be, picking up on Maureen's point about well-being as well, but that we're flourishing, thriving, not just surviving.
And thriving really encompasses so many of those elements that we talked about. I can't thank you enough, really. Maureen, Al, Michelle, Liz, this has been a terrific discussion. I only wish that we could continue this for another 2 hours on a cup of coffee. I've learned so much as we speak, so thank you very, very much. And this actually concludes our summit. We've been working on this summit for quite some time here at MWRI. We've been trying to be encompassing for a variety of topics. We've been trying to incorporate very diverse points of view, and our intention, and I think we achieved it, has not been to show complete data or to brag about our scientific success. We really try to uncover questions, to identify controversies, and to make all of us think differently. And I think this final discussion that the four of you contributed to really added much more to us thinking differently, not necessarily just accepting current, present solutions, but really trying to redefine future solutions for all of us. And this is about women's health, it's about people's health, but it's really about humankind health. I very much appreciate, Liz, what you said about the 1 or 2% of children being 100% of the future. That's what we say about pregnant women.
Right.
There's only 1% of American women pregnant at any time, but they carry 100% of the future of humankind. And this discussion was so essential for our future. So thank you all very, very much.